Guys, welcome to our lecture on burns. I'm here, Andrew. I'm here with Brittany, Brian, Kelsey, and Monica. So starting off with classifications on burns, 5 different types: your superficial partial thickness, deep partial thickness, full thickness, and deep full thickness, all categorized by color, edema, pain, blisters, eschar, healing time, and if there's a graft required. And then we have some examples on the bottom. With hydrotherapy, remember it could be at the bedside, done by UAP or PT, or as well by nurses. We will do the assessing. It could be on a shower bed where water can be better controlled with temperature-wise. And we just wash the localized area. Bathing or immersion is no longer performed due to the increased risk of infection. And then daily we will examine the wounds. Nurses and skilled techs use forceps to remove the loose dead tissue during hydrotherapy. Remember to leave your intact small blisters, and the larger blisters will be debrided from the cheesy eschar with a gauze sponge. Remember to wash your burns with mild soap and water, and then rinse with a room temperature water.
Hey, how's it going? This is Brian. Because this video's got a maximum of 15 minutes, I got to rush through this. So the rule of 9. So the quickest way to calculate total body surface area, or TBSA, of a burn injury. It divides the body up into sections that are represented by multiples of 9, so it does require some memorization. So knowing the TBSA of a burn, it's important because it's a significant component of planning interventions such as fluid resuscitation, because you got to calculate stuff out. So the rule of 9s, so the whole head is 9, each entire arm is 9, each entire leg is 18, and the trunk or torso is 36 in its entirety. So if you memorize those, you can figure out what the percentage is by just thinking, if half the arm is burnt, you just cut 9 in half, 4 in half. So front half is 4 and a half. If it's just half of the front of the arm, the anterior arm, and it's only from the elbow down to the hand, then that would be like 2 1/4. For example. So knowing how much each body area is worth will help you approximate burns that only cover a portion of an area, like I was talking about. So what if only half the chest is burnt, or 1/3 of the chest? So fluid resuscitation. So burn patients required fluid replacement to maintain adequate blood volume, cardiac output, mean arterial pressure, and tissue perfusion. So the most commonly used fluid resuscitation formula is the Parkland formula. So just memorize this. Remember 4 mLs times their weight in kilograms times percent TBSA burn. So that's why you need the rule of 9s right there for that final component. This total volume is to be infused over the course of 24 hours, and that 24-hour clock starts from the time of injury, not the time of admission to the hospital. So you have to find out when they got burnt, not when they arrived at the hospital. So just remember, this helped me memorize it, so just remember 888, 50, 25, 25. So calculate your full volume. In the first 8 hours, half of that volume has to be infused. Okay, so if they got burned 2 hours prior to being admitted to the hospital, then you actually have 6 hours to infuse 50% of that total volume. And then the second 8 hours, 25%, and the third 8 hours, 25%. So again, like I was saying, remember, you have to know what time they got burnt, because that's the important time frame.
So immediately after burn injury, there are many systemic changes. In vascular changes, there will be circulatory disruption. Blood vessels are occluded, blood flow is reduced or stopped, major blood vessel constriction is seen, and blood vessel thrombosis may occur, leading to necrosis. There is massive fluid loss through evaporation, and extensive burns result in generalized edema and decrease the circulating intravascular blood volume. Extensive edema is present, especially within the first 12 hours. Fluid shift, also known as third spacing, occurs after the initial vasoconstriction. Impaired fluid and electrolyte balance leads to continuous leak of plasma fluids and proteins from the vascular space into the interstitial space. Decreased volume, blood volume, and decreased blood pressure are seen. Fluid losses result in decreased organ perfusion And some of the imbalances include hypovolemia, metabolic acidosis, hyperkalemia, hyponatremia, hemoconcentration, which develops from dehydration, reducing blood flow, and increasing tissue hypoxia. Cardiovascular changes include increased heart rate, decreased cardiac output, which may remain decreased until the next 18 to 36 hours after injury, and as mentioned before, decreased blood pressure. Proper fluid resuscitation and support with oxygen prevent further complications. In pulmonary changes, direct injury to the lungs from contact with flames rarely occurs. Respiratory problems are usually caused by superheated air, steam, and/or toxic fumes, which are irritant to the alveoli and capillaries. In acute burn phase, respiratory insufficiency is secondary to edema, which can lead up to pulmonary insufficiency, infection, and often results in death.
Immunologic changes and infection. Changes to the immune system after burns are usually immediate and severe. After experiencing a burn, skin integrity is compromised, leading to a greater susceptibility to infections. Burn injuries lead to an inflammatory response that causes the immune system to be suppressed. Antibiotics and other medications given during the resuscitation phase may increase the patient's risk for lowered immune function and infections. The patient is at the highest risk for infection when the burn injuries are still open. Effects of burns on the gastrointestinal system. After experiencing a burn, fluid shift in the body occurs, which leads to a decrease in blood flow to the GI tract. In addition to the fluid shift, the body secretes epinephrine and norepinephrine, which causes a decrease in gastric motility. With the decrease in gastric motility, the patient is at risk for a paralytic ileus. The early use of medications such as H2 histamine blockers and proton pump inhibitors help to protect the GI tract and prevent the occurrence of burn-related gastric ulcers. So, burns and metabolic changes. Severe burns lead to a hypermetabolic state that can last for a year or more after injury. Prompt nutritional support is important because this hypermetabolic state leads to an increased calorie and oxygen need. Complications that may occur without nutritional support include muscle wasting, organ dysfunction, and delayed wound healing. There is not a set protocol for providing nutritional support after burn injuries, but it is recommended that it should be initiated within 24 hours of the injury via an enteral route. The hypermetabolic state also leads to a rise in core temperature that is a response to the body losing heat through the wounds. This response may cause a low-grade fever.
Okay, resuscitation phase priority assessment. You have the respiratory. Airway is your priority. Inspect the patient's mouth, nose, and pharynx. Burns to major parts of the face and inside the mouth are strong indicators of inhalation injury. It's critical to know if a patient has a sudden development of a brassy cough, drools, or has difficulty swallowing, or produces advantageous breath sounds on exhalation. It is a medical emergency. For cardiovascular, patient who receives burns is subjected to fluid and electrolyte imbalance, which is hypovolemic shock. Assess for signs of hypovolemia and decreased cardiac output. Thus, assess a patient's peripheral pulses, blood pressure, capillary refill, and pulse oximetry. If burn was of electrical in source, then assess for EKG changes. As the kidneys are not being perfused well, urine output is decreased during the first 24 hours. We know this formula, the output should be 30 to 50 mLs per hour or 0.5 milliliters per kilogram per hour. Assess the patient's response to fluid resuscitation via urinary specific gravity, BUN, creatinine, sodium levels, and hourly urine output. For gastrointestinal, reduce the blood flow to the GI tract causes hypoactive and absent bowel sounds. Paralytic ileus may be noted with patient presentation of nausea, vomiting, and abdominal distension. For integumentary, refer to the rule of nines. For resuscitation phase laboratory values, you have your hemoglobin, hematocrit, and BUN are elevated as a result of fluid loss. Glucose is elevated as a response to stress. Sodium is decreased due to sodium being trapped in edematous tissue. Potassium and chloride are elevated. Protein and albumin are lowered, and carboxyhemoglobin can be elevated as a result of inhalation of smoke and carbon monoxide. For acute phase priority assessment, for respiratory, you have the patient may develop pneumonia as a result of going into respiratory failure, which would require the patient to need mechanical ventilation. For cardiovascular, you monitor the patient for signs of hypervolemia as a result of overinfusion of fluids. For neuroendocrine, you want to weigh the patient daily in order to determine overall weight loss. A 2% loss of body weight indicates a mild nutrient deficit and weight loss, while a 10% or more weight loss requires evaluation and modification of the patient's caloric intake. For immune, you want to monitor for signs of infection and sepsis. For local signs, the deterioration of burned wound from partial thickness to full thickness, edema surrounding the wound, you have ulceration of burns, and excessive drainage from burn or odor. For systemic signs, you have altered LOC, vital signs, which can be tachycardia, tachypnea, increased temperature, hypotension. You have oliguria, onset of GI dysfunction, which will be diarrhea, vomiting, abdominal distension. You have hyperglycemia, WBC changes, and hypoxemia. For musculoskeletal, patients are at risk for immobility, thus assess the patient's passive and active range of motion throughout stay and provide special attention to joints around burn injuries. For acute phase laboratory values, you have hypokalemia, which can occur due to overinfusion of normal saline. You have hypernatremia, which can continue from the resuscitation phase and can occur from hemolysis of blood cells or disruption of sodium potassium pumps. You have hyponatremia, which can occur from prolonged IV therapy and be a result of hemodilution. Now, during the rehabilitative phase, you have the priority assessment. In this phase, performing an in-depth psychosocial analysis of the patient is necessary. Even though this does not occur as more of an acute care setting, it's still good to know. You want to look for signs of depression, post-traumatic stress disorder. You want to ask the patient about feelings towards possible sexual dysfunction and feelings about healing of their scars. So, question. Which type of burn injury appears in black, has no edema, and is typically painless? Pause the video now if you need to. Good, it's deep full thickness.
Alright guys, so pause the video again if you need to. So 25-year-old female patient was brought to the ER after suffering burn injuries from a grease fire in a kitchen. So burns covered both anterior forearms and hands, the anterior portion of her entire right leg, and her genital region. What percentage of body surface area was burned? Is it 19%, 14.5%, 13.5%, or 27%? And so both anterior forearms, so that's 2.5 or 2.25 plus 2.25 plus 9 for the entire anterior right leg, and plus 1 for the genital region, which is B, 14.5%.
An 8-year-old male is brought into the emergency department via ambulance after surviving an apartment fire with no visible burn injuries present. With newly onset symptoms would signify an medical emergency that would require the nurse's priority action. A, restlessness and anxiety. B, a brassy cough with difficulty swallowing. C, blood pressure of 110/86. Or D, hypoactive bowel sounds. Pause the video to look at the question. Good. It's going to be B, brassy cough with difficulty swallowing. These are our references. This is the end of our presentation on burns. Thank you for listening.